Okay, let's try now. If you're not ready, can you raise your hand up high? 1, 2, 3, 4, 5, 6. Okay. So can you think of a way to take advantage of these side effects? Can we use these side effects as a pharmacological effect? Okay, give me examples. Surgery. Okay, surgery. Okay. Although I have to say that whenever we say anticholinergic, we actually refer to the muscarinic receptors, not the nicotinic. Okay. So we'll talk about this in today's application. So in surgery, we have the anti-nicotinic because it actually blocks the muscles, paralyze the person. And these are locally effects, not systemic. Okay, other examples. Can you think of an example where we, yeah. Okay, so if you keep trying, if it doesn't work, I'll give you a copy, a paper copy, okay? Oh, it started. If you accidentally start the exam, it's only 10 minutes, so it's timed. So go ahead and start, okay? So I'll be quiet then. Let's see who's not ready. Can you raise your hand up high if you are not ready? Only one person. Okay, so guys, go ahead and start, and I'll give you a paper copy, okay? Anybody else needs a paper copy? Can you raise your hand? Please raise your hand up high. Just one person. Okay, you could start working as a team now. I'm gonna set the timer. Okay, you could Okay, so let's go through the questions together. Okay, the first one, what statement regarding the autoreceptors is most correct? Let's go through them one by one. They are located at the postsynaptic neuron. Where are they located? Presynaptic, right? If this is the neuron, right? Presynaptic, postsynaptic, this is the synaptic cleft. This is where the autoreceptors are, okay? And by the way, this applies to many other neurotransmitters, okay? It's not just for the acetylcholine. We will see that with the adrenergic receptors, the histamine, and all kinds of receptors. Anytime we say autoreceptors, they do the same kind of work, okay? And it's a little bit tricky because you stimulate the receptor, but then what happens is it will give a positive or negative effect. Negative effect, yes, Melody. So the presynaptic, the autoreceptors are located at the presynaptic. This is presynaptic, postsynaptic. This is the synaptic cleft, okay? So always they are located presynaptic and they give a negative feedback, which makes sense because what happens is when you have more of the neurotransmitters, then those extra additional neurotransmitters will eventually reach to the presynaptic receptor and tell the neuron to stop sending these neurotransmitters, right? It's telling the neuron to, we have enough of these neurotransmitters, so it gives a negative feedback, okay? This applies to all kinds of receptors. Yes, sir. Okay. Thank you. This is better, right? Okay. So presynaptic, synaptic, postsynaptic, and the autoreceptors are always located in the presynaptic, okay? So whenever the neurotransmitters, whenever we have excess of these neurotransmitters, extra neurotransmitters, they eventually reach to this site and block the release of whatever the neurotransmitter is. It applies to the histamine, acetylcholine, muscarinic, all kinds of receptors, okay? All right, and second option, binding of acetylcholine to autoreceptors promotes the release of more acetylcholine. It actually inhibits. It inhibits the release of acetylcholine. And then autoreceptor catalyze the hydrolysis of acetylcholine. Which one is, what's the name of the enzyme actually that catalyzes the acetylcholine? Acetylcholinesterase, okay? And they're actually normally located here next to the target receptor, okay? So the neurotransmitter, they bind. Once they finish, they bind to the enzyme here, the acetylcholinesterase, which breaks down the acetylcholine, okay? Okay, so the answer is none of the above. Any questions about this? Any issues about it? No? Clear, everyone? Okay. Next. What statement is correct regarding acetylcholine, or most correct? Acetylcholine can be administered orally? No? Why is that? It's not stable because of what? Hydrolysis by the acid, hydrolysis by the enzyme. It's an ester, right? Even if they are taken, let's say by IV, they get to the blood, they get hydrolyzed by the esterase enzyme, okay? And what else? Plus, there is one issue about not stability, but selectivity. What if we take acetylcholine by injection or orally, or what's going to happen? It's going to hit all receptors, right? Nicotinic, muscarinic, all kinds of muscarinic. So it's horrible. You cannot selectively affect one part of the body. And then acetylcholine binds to the nicotinic and muscarinic receptors using different conformation. We all agree that this is correct. What does that mean? Have you guys watched the video I did on exercise number, I think 7 or 8, about the conformation, how the acetylcholine binds to 2 different receptors? No, you have not? How dare you? So there was one of the application exercises when we learned about the isomerism and stereoisomers, we talked about conformational changes. Okay, what's a conformation? Remember? It's a rotation around a single bond. So acetylcholine, because of the rotation around a single bond, can form 2 different conformations. One fits the muscarinic, one fits the nicotinic. Make sure you check the video. It actually will make sense once you watch it, okay? So it does bind to 2 different conformations. And then acetylcholine binds to adrenergic receptors. No? What kind of receptors does it bind to? Muscarinic or nicotinic? Okay. Question number 3. Okay. So propanthyline, which is this drug here, acts as an agonist on muscarinic receptors. Well, it says here it's an antagonist, right? So it's actually an antagonist. So we all know that's not correct. And then van der Waals binding regions, which is these regions here in circle, they cause an induced fit different from that produced by acetylcholine. I'm sorry, you cannot see that. Okay. Do you guys agree? Okay. So why is this important? Remember the induced fit? So what's going on here? How does it work as an antagonist? Why binding to that region? Exactly. So the wrong induced fit means it's gonna produce a different conformation that's, it's not gonna stimulate the signal, okay? And propanthyline acts as an antagonist on nicotinic receptors. Does it act on the nicotinic receptors? This is actually the SAR for the muscarinic. Okay, so as we will see, nicotinic actually, they don't care about all these features. They only need 2 positive charges within certain distance, and that's it. They'll block the nicotinic receptor. We will look at that later. All right, issues about this or anything before that? Yes. Yes, so this is the SAR for the muscarinic receptor. So it actually has the positively charged amide, the carboxylic acid forming hydrogen bond. This forms ionic, which are actually in this rectangle or square. It is the requirements for the acetylcholine binding site. So these are the requirements for an agonist, okay, without this. So if we only have these, then they will produce the correct induced fit and get the signal, right? Now, just because we add this function groups, we will have extra binding that will produce unpreferred induced fit. That will give incorrect induced fit and cause an antagonism. Okay, does that answer your question? Okay, John?
Was this question, I don't know if it was in the chapter, maybe something you were testing on, but propanthyline, was this question asking if we knew what propampoline was? Okay. Because
Right. So it's
I know that in the key it says van der Waals region binding thing down at the bottom, and I would have liked the question a little bit better if it had said propampoline is an antagonist for muscarinic receptors.
okay.
Because I was sitting here going, well, I don't even know if this is an antagonist or agonist, so it doesn't matter if it's an antagonist to nicotine if I don't even know if it's an antagonist to muscarinic, and I've kind of went with it quickly, but I was just.
Okay, fair enough. I'll check the results of the class and see if there is an issue with this question or any other questions. I will take care of them, okay? Any other issues? You're quiet today. What's wrong? What? This was hard? Oh my God. Why? Was it, the material was not, was it too much? Okay. You really work as a team. Okay, okay. Well, yeah, that's the first. Yeah, once given time, this is. Well, I assumed we did good job with the basics, so I assume that you guys are ready to rock and roll. No? Okay, that's fair. I'll look at the results and then, make sure, the outcome is okay. I'll take care of it. Melody, yes. Go ahead.
More like what you're going to ask on a cat? It doesn't seem like that. Would this be like the kind of questions you're expecting?
It's like. Well, to be honest, when I put the questions, I mean, try to cover, some like 30% would be like straightforward answers, 30% middle, 30% higher, and then 10% bonus, but no. Anyway, so normally I try to divide them, but I cannot tell until I see the results, right? So I didn't know that this is going to be hard on you guys. I try my best, but then sometimes you see that, students are struggling with this. So then I adjust and try to, so it's not, so CAT, normally they are more, analytical. Yes, I mean, they're harder because you rely on, so rats are just for you to be prepared to read the material, right? You're not expected to master the material, but then once we have the discussion, the class, then you're expected to master the material, and then cats will be more difficult, okay? This is the trend, but so it's really hard to tell how the students will perform until you see the results. The goal is to have, distribution of questions between easy, medium, and hard. So, okay. Right. Other questions? Yes. Okay. Sure. Okay. 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 So I'll look at the results and make sure the questions are fair and make sure it's in line with the results of the other rats. And after today's class, hopefully all these concepts will be clear, okay? So just work with me with the questions. The more you ask questions, the more we help each other, okay? So hopefully eventually you will get the overview concept, and you don't have to memorize things. Once you know the basics, then you'll be able to just find the answer easily, okay? Okay? Right, next question. Nicotinic antagonists are useful in nicotinic. Oh, I'm confusing myself here. All right. Nicotinic antagonists are useful as neuromuscular blockers in surgery. We all know this is correct. Well, I hope so. You will see that there's nicotinic receptors and there's muscarinic, okay? So I'll save the explanation once you get to the first exercise because it will make sense more. What statement is most correct? Nicotinic receptors belong to GPCR receptors, okay? They belong to ion channel. Nicotinic are ion channels, okay? And then both nicotinic and muscarinic belong to the same superfamily. No, one of them is actually, the nicotinic is ion channels, muscarinic is GPCR. Muscarinic receptors are intracellular, not bound to the plasma membrane. Actually, both muscarinic and nicotinic are bound to the plasma membrane. So it's none of the above. Yes, Kendra. No, actually, they are different superfamilies and they are different classes. So superfamilies are ion channels, GPCRs, kinases, intracellular. So each one of these belong to two different superfamily, okay? Yes, ma'am. Say it again. Both are cholinergic receptors. What would you call the family they belong to? Okay, they actually don't belong to any like family that there's not any common features between these two receptors. So nicotinic are actually ionic channels that are totally different from GPCR. So these channels, when they are activated, they allow the influx of the ions, and that's it. That's their jobs. GPCRs, they get stimulated, they kick the signal transduction, and it's totally different story. And that's why you have a different binding site for the nicotinic than the muscarinic. Okay, makes sense.
In page 7 of the reading, it says we're both cholinergic agonists, but they have different physiological effects. So I guess I'm
Okay.
confused everybody.
So the agonist analogs or the acetylcholine binds to both receptors, okay? But it produces different physiologic effects as a result of binding to each one of the receptors. Okay. Any other questions? Yes. Say it again. I'm sorry.
Why did you say C was wrong?
Oh, C, muscarinic receptors are intracellular receptors that are not bound to the plasma membrane. If you remember the types of receptors, we had ionic channel, we had GPCRs, we had kinases, and we had intracellular. Intracellular, these are the ones that are floating inside the cell, and they are not bound to the plasma membrane. And these are the receptors that once they're activated, they actually go to the DNA and stimulate the synthesis of proteins, enzymes, or they inhibit the synthesis of proteins or enzymes, okay? Now, muscarinic or nicotinic, they are not intracellular. They're actually, both are bound to the plasma membrane. One of them is an ionic, the other one is GPCR, okay? You guys are so depressed. Okay. Don't think about the grades, okay? I'm serious. I mean it. I'm trying to think about learning, not about the grades. I mean, I wish there is a way we could say just no grades and just come here and learn, but then nobody would show up. I know. So this is just an incentive to, have you guys learn, but, don't think about the grades. I mean, I wish I could look at the results now and make you feel happier, but I cannot promise anything until I see the results, okay? Okay. So try to focus on the concepts and see what you are missing instead of, what you missed on the rat, okay? Okay, next one. What statement regarding anti-cholinesterases is most correct? Carbamate form reversible binding with the acetylcholinesterase enzyme. Can you see it? What is it? Yeah. So carbamate, we all agree this is correct, right? They form reversible binding with the acetylcholinesterase. Yes, Melody? It is actually, yes. So it's reversible, and we will see that it's because of the carbamate group or the urethane group that the drug binds for longer amount of time and basically stabilize the binding and prevents the enzyme from working. Anti-acetylcholinesterases cause increase in the cholinergic effect. Okay, we all agree that it does cause increase in the cholinergic effect because the esterases they break up the acetylcholine. So if we inhibit the acetylcholine, then more of the acetylcholine will be available. Organophosphates are used as insecticides. We've seen that, and then so the answer of the above. Any issues about this question? Yes, Melody.
Can you just explain to me a little bit? Because I would have thought the opposite.
Which one?
On
Okay, so cholinesterase enzymes, what's the job of these enzymes? What is the job of the cholinesterase enzyme? Okay, they break down the acetylcholine. Okay, so anti-cholinesterase enzyme, these drugs, they inhibit that enzyme. So when you inhibit the enzyme that breaks the acetylcholine, what's going to happen? You're going to have more of the acetylcholine. Okay? Okay. Any other issues about this one? Muscarinic receptor antagonists are used as smart drugs to treat patients with Alzheimer's disease. Is this correct? Well, not. Why is it false? Agonists, actually. They should be agonists that treat Alzheimer. Okay, so people with Alzheimer, they have less muscarinic receptors, and our goal is to increase the acetylcholine. So we provide agonists, okay, or we actually provide the anti-cholinesterase. Okay, so the ones that inhibits the cholinesterase enzyme. The action of noradrenaline at various tissues is opposite of acetylcholine. I think we all agree this is true. What statement is most correct? Muscarinic receptor agonists can be used in treatment of glaucoma. Right? And then muscarinic receptor antagonists can be used in dilating the pupil for medical examination. Can you give me an example of that medication? Atropine, okay. And then adrenergic receptor agonists can be used in treatment of asthma. We will look at the table in the applications that will put everything together so you could actually see the difference between, compare between them. Last one, distribution of different types of adrenergic receptors in different parts of the body is good in designing selective drugs. True, why is that? Why is it advantageous to have different kinds of receptors located in different parts of the body? Say it again. We could design specific drugs for these receptors and maybe administer them in these sites. This way we could avoid the side effects, okay? Imagine if all the receptors are the same and they are distributed in, in all the tissues, then if you give an agonist or antagonist to that receptor, it's horrible. It's going to affect all the body, right? But then we have different receptors located in different parts of the body, so we could actually help us in selectively acting on one receptor in certain parts of the body, but not the others, okay? Okay, any questions about the rat so far? Yes, Melody.
That last question, I could have told you all that, but it was just worded in a way that I wasn't sure what I had a hard time following it, I guess.
Okay, I'll look at it after and then see how much trouble was this question. Do you have a question, Cheryl? Uh-huh. Yes, so the agonists are the ones that work as smart drugs, okay? An example of this are the anticholinesterases, okay? Any issues, concerns with the rats? Okay, again, forget the grades, okay? Cheer up now. I still see the breast faces. Huh? You're smiling, that's right. Right, I promise I'll take care of this rat, okay? I'll look at the average and then, I'm sorry? But don't put the subject in it. Well, after today's class, we'll see, okay? We'll see how clear these concepts are and then, okay? You have a question, John?
It's not actually a question. It is a concern.
Okay, it's a concern, okay.
This one, the reason, one of the people like that, the question, I was like, am I supposed to know what this is? I had to skim it instead of, if I'd looked at it long enough, I would have seen agonist going, oh, this might be a giveaway what this is, but it wasn't labeled, so I wasn't sure about that. But questions like not, which I had to sit there with the anti and the like cholinesterases
Okay,
and like you're doing anti and thinking that was involved in question nine.
okay.
I just was sitting here, if you made a test with a whole lot of those questions, although totally valid, not misleading,
Okay,
I'd be sitting here going, one, two, oh, and I know it took me longer on this one than any of the others. Like
okay,
a lot of them I'd go through and be like,
okay.
maybe too fast.
Okay, so I see, this explains the concern that you have. I guess the questions were like, I guess, relying on more than one concept to solve, right? I mean, to find the answer. It's like multiple, concepts combined together. It's fair, so don't worry about the rat. Let's see how we do it in today's lecture. So go have a break, 7 minutes, and come back fresh, okay? 7 minutes break, refresh, come back ready for, more. All right, I hope you had a nice break. So start working on the first exercise. In fact, this exercise will give you a really good overview of all these kinds of different receptors and applications. Hopefully, it will make a full sense to you once you see that, okay? So once you do that, you should be able to see the full picture of these acetylcholine agents, agonist, antagonist. So I want you, as you fill the table, to look at this chart here, okay? So this chart basically summarizes all the kinds of acetylcholine receptors. And as you fill the chart, make sure you look at this. As you fill the table, make sure you look at this chart and see what the effect, how these receptors act, okay? So as you know, in the CNS, there is the somatic receptors, somatic neurons that they affect the skeletal muscles, okay? And when we act on the nicotinic, receptors, we block these receptors, we get what? Paralysis, right? Except if these drugs get absorbed and go into the circulation, into the systemic circulation, where can they affect the nicotinic receptors? Where do we have nicotinic receptors? In the ganglia, right? Here and here, right? So what effect would you expect, sympathetic or parasympathetic? But they're opposing each other, right? So it's really hard to tell. So you will see some contradicting effects. Okay, you might see like, drug, increasing the heart rate, but causing vasodilation, right? You might see, so it's horrible. That's why these anti-nicotinic, they are actually administered locally. Like in the case of the surgery, we only apply it locally in this part where I need to work to paralyze the skeletal muscles for this part alone, okay? But they're not supposed to be absorbed. So keep that in mind. And then when you look at the muscarinic, you see more selectivity. So the muscarinic are only located here. And then the adrenergic are only located here. But these two have opposing effect. So keep in mind this graph, as long as, along with this here, the balance, the opposing effect of the muscarinic, okay, and the adrenergic receptors. So the balance, whenever we talk about balance, it's actually between the muscarinic and the adrenergic receptors, okay? One of them opposes the other. At normal situations, which one is more dominant? The parasympathetic, right? Which is muscarinic, right? The rest and digest, okay? And when you have an exam, which one works? Sympathetic, okay? So which is the, fight or flight, okay? Now, you can get one effect or the other by affecting these two systems. If you provide agonist for one system or antagonist for the other, you get one effect. If you do the agonist for another system or antagonist for the other, you get the other effect, okay? So keep that in mind as you fill the table, and then we'll start discussion, okay? So let's set maybe let's say until 10:20. So at 10:20, we'll start discussing these, okay? This table will give you a general overview, will simplify things for you such that you will have an overview of what it means to have, agonist, antagonist, and the different kinds of receptors, okay? Are you guys ready? Okay, you need a few more minutes? Okay. Okay. Are you ready now? Okay. Hopefully you're less confused so far. Now? Okay, let's try. Let me start by some questions first, okay? So what happens if I design a drug that affects the nicotinic receptors, regardless whether it's agonist or antagonist? Let's just pretend that we'll design a drug that will produce an agonist effect on the nicotinic receptors. Based on this graph, what's going to happen? First of all, where are the nicotinic receptors? Skeletal muscles. Where else? Ganglia. And the other ganglia here, which are part of, this one is part of the sympathetic, this one is part of the parasympathetic, okay? So if I design a nicotinic agonist, what's gonna happen? Starting with the skeletal muscles. What's gonna happen to the muscles? Contractions, right? What's gonna happen to the organs? As you know, organs, as you see in these pictures, each organ is actually supported by both sympathetic and parasympathetic, okay? So back to this. So if I have a nicotinic agonist, what's gonna happen to the organs? Are you gonna see a sympathetic or a parasympathetic effect? How can you have both? Okay, if I design a nicotinic agonist, a drug that stimulates the nicotinic receptors, okay? We all know that it's gonna cause muscle contraction. Now, what's gonna happen to the other organs that are affected by both systems, knowing that nicotinic is part of the ganglia here and here? Someone says that there might be a balance, one cancels the other, that's possible. What else? So I would say, so if it goes to one ganglia but not the other, depending on the distribution, you might see one effect but the other. So you might see one effect over the other for some organs, but not the other. But for one organ you might see sympathetic, for another might see parasympathetic, depending on how the drug is distributed. So it's confusing, right? So it's okay to be confused in this case, right? It is confusing because the nicotinic receptors, if they are targeted as an agonist or even as an antagonist, you get horrible effects, okay? Make sense? So we should avoid having nicotinic agonists unless we can control the effect of these drugs on the skeletal muscles locally, okay? Make sense? Now, what happens if we design a nicotinic antagonist at the skeletal muscles? Paralysis, right? All these, atracorium, whatever the corium thing, and the dexamethasone, and all these horrible neuromuscular blocking agents, okay? And what happens to the other organs? Again, confusion, right? We're not sure what's going to happen. It could be, this or that. So we should avoid using nicotinic antagonist systemically, okay? Only locally on skeletal muscles during surgeries, for example. Make sense? Now, I don't want to confuse you, but there was a question Kevin was asking, which is how these anti-nicotinic drugs are given by IV, how you can control that the drug will actually affect one part of the body but not the other. I could not answer that question. but there must be some way to actually make sure that the drug only goes to these skeletal muscles, but not the other parts. If you ever have training in a hospital and you see that, then this is something you might think about. But anyway, Melody.
So you said for nicotinic antagonists, avoid this as well because you end up with chaos.
What do you think? So nicotinic receptors, if they go systemically, they affect both sympathetic and parasympathetic. So you can have unpredicted effects, okay? So the only use for nicotinic receptors, either as an agonist or antagonist for locally at the skeletal muscles, okay? Okay, guys? So like in the case of a surgery, and in the case of myasthenia gravis is when somebody cannot control their muscles, so they use the nicotinic agonist to actually help them control their muscles more, so enhance the muscle contraction. We got this part? Everyone got this part? Can you raise your hand? Or do this if you're not 100%. So you see, okay, well, questions then. Questions about that? Yes, Melody.
So you said nicotine antagonists for myasthenia gravis because
Agonists. So the nicotinic agonists, I'm just giving an example of one example of when you could use a nicotinic agonist. In the case of myasthenia gravis, these are people who cannot control their skeletal muscles. So we provide the nicotinic agonist to help them control their skeletal muscles, okay? And in the case of the nicotinic antagonist is when you block the skeletal muscles for surgery. Or like in the old days, they used to have these arrows that have the anti-nicotinic drugs at the tip of the arrow. So such that when they shoot the animal, it causes paralysis for the animal so they can catch them. Yes, the curarium. Okay, the
Poison dart.
yes, poison dart. Yeah, thank you. All right, questions? Before we move to the next part, questions? All right, let me check again. If you get what we said so far, 100%, raise your hand. If not, do this so I can see. Okay. Okay, that's better. You have a question, sir? You have a question? Not anymore? Okay. Yes. Okay, so in the nicotinic antagonist, they can block this and cause skeletal muscle paralysis. They paralyze the skeletal muscles, and that's why they could be used in the surgery to paralyze, the part where you're actually performing the surgery, so that they do not move. Okay. Now, we should avoid having these drugs being absorbed systemically, because if they do, then they can affect both sympathetic and parasympathetic, and then these effects are contradicting. So as you have seen, the sympathetic opposes the parasympathetic, and each organ is actually supplied by both adrenergic and sympathetic and parasympathetic through the adrenergic and muscarinic receptors. Okay, so this brings us to the next step, which is what are the receptors that are responsible for producing sympathetic effects? We already agree that we should avoid nicotinic receptors. So if I need to stimulate the sympathetic effect, if I want to have the effect of increasing the heart rate, all these fight and flight effects, which receptors should I target to get these effects, the sympathetic effect? Adrenergic, agonist or antagonist? Agonist. So adrenergic agonist will give you the sympathetic effect, right? Right? Everybody agrees? Okay. So adrenergic receptors, if we design agonists, or if we stimulate the adrenergic receptors, we're going to have the sympathetic effect. Okay? Everybody get that? Raise your hand. Okay. Now, is there another way to stimulate the sympathetic effect? Blocking what? The muscarinic? Yes. Why is that? Yeah? Yeah? Okay, because there's a balance. Each organ is actually supplied by both sides, right? So one way to stimulate the sympathetic is by giving adrenergic agonists, by stimulating the adrenergic receptors, okay? But since there is a balance, another way is what? To block the other, muscarinic. So basically you block this parasympathetic, and then you're still gonna get that. Because one of them basically overrides the other. Let's actually let's finish this, and then we'll hopefully maybe do a demonstration. We'll see how that works. Okay, so far we all agree that if we stimulate the adrenergic receptors, we get the parasympathetic, and hopefully we all know that if we block the muscarinic, we also get sympathetic, because each organ is supplied by both sympathetic and parasympathetic, or let's say both adrenergic and muscarinic. So by stimulating the adrenergic, it takes over. But then another way you can also stimulate the adrenergic is by blocking the muscarinic. So you block the muscarinic, you block the parasympathetic, so then the adrenergic takes over. We all get that? Can you raise your hand if you got that 10%? Or if not, do this so I see it. Okay, so the same. Okay, Melody.
Did you say that not all the adrenergic was the sympathetic? Did you say to block the adrenergic to stimulate the sympathetic?
What do you think? What do you think based on this? Which nerves are responsible for the sympathetic? Like which nerves are, would be responsible for stimulating, producing sympathetic effect? Adrenergic receptors, right? So if we stimulate the adrenergic receptors, we get the sympathetic. And these two oppose each other. So if we block this, you also get the sympathetic effect, okay? Now, if we get that, then the second concept is easy, because it's just the same logic. So in order to get the parasympathetic effect, can you tell me a way to get the parasympathetic effect? Muscarinic agonist. So we stimulate the muscarinic, or block the adrenergic, okay? That's why in the table here, I said stimulating parasympathetic or blocking adrenergic, because you're gonna get the same effect, the parasympathetic. Here I said stimulating sympathetic or blocking muscarinic, okay? Notice that we do not talk about nicotinic, and if we talk about nicotinic, then at the ganglia, we get this confusion, question mark, okay? If we talk about nicotinic at the skeletal muscles, then we could cause muscle contraction or muscle blocking. Clear, everyone? Make sense? Okay. Questions? Yes, ma'am. On the where? Which receptors? Yes. So in the Oh, and the ganglia, no. And the ganglia, it's we don't know the effect because again, it's gonna be contradiction. See, it's gonna be contradicting effects. If you act on the nicotinic receptors at the ganglia, we have two nicotinic receptors here, so we don't know what's gonna happen whether the sympathetic or parasympathetic effects. Okay, so we only use nicotinic receptors. We only target nicotinic receptors if we are, dealing with the skeletal muscles. Okay. So you get the idea of the balance between how the opposing effect and how each organ is actually influenced by both systems. So you could enhance one system or inhibit the other to get the effect you want. You get that, guys? So which one, under normal situations, which one is actually dominating? Parasympathetic, right? So under normal situation, we have the parasympathetic. Now, if you get into, the exam part, then the sympathetic actually takes over, okay? I was gonna do a demonstration, but I'm not sure if we have time. I'll try to do it really quick here, so. Okay, let's see, let me get 1, 2, 3, 4. Actually, maybe just 2 volunteers, I think will be fine. Let me get 2 volunteers, yes. Okay, so one of you is gonna be the sympathetic, and one of you is gonna be the parasympathetic. You're the sympathetic? Okay, you're the parasympathetic, okay. Okay, you guys are gonna pull this against each other, right? I mean, like, try to pull like your, the, what do you call it? Like pull the rope, see which one's gonna win, okay? Yeah. So normally, which one is actually winning? The parasympathetic, okay? Okay, so on each organ, you have these opposing effects, okay? And then I use the color code here. So green, which matches his shirt actually, is the muscarinic agonist, okay? Or you could use adrenergic agonist, okay? So let's see. So normally they are pulling each other, and then normally he's the winning, he's the one who's winning, right? So in the case of the muscarinic agonist, I would help this guy here and, make him even more dominant, okay? Another way to produce this effect is adrenergic what? Antagonist. So what happens here? You are pulling, and then what I'm gonna do here, I'm just like, basically, I'm sorry, basically antagonizing her action, okay? Like preventing her or like not helping her, okay? So that's the adrenergic antagonist, okay? Now you get the point. So the other way is adrenergic agonists. So what's gonna happen here? In the case of adrenergic agonist, I'm gonna help her. So I'm gonna help her and give her a hand. So now we're at the sympathetic, okay? Now, if I use the muscarinic antagonist, you're a guy, I can push you. So that's right. So in the case of the muscarinic antagonist, I could just, work against him. So now the other side takes over. Is this better now? Is it? Okay, I'm glad I did it then. Thank you so much, guys. Okay, so now that you understood the concept, the only thing you have to do is just filling the table. So let's do it together, okay? Okay, so what happens? Sympathetic, what happens to the heart rate and contraction? I'm sorry, parasympathetic. So we have decrease in the rate, heart, let's say HR, and decrease in the heart contraction, okay? Sympathetic, we have increase, okay? The blood vessels, in the case of the sympathetic, again, they relax. So we have vasodilation. Here we have vasoconstriction, okay? GI work in the parasympathetic. So they have increase of the GI activity. Here we have decrease GI activity. The same thing for the urine tract, increase the urinary tract. Here we have decrease in the urine tract, right? Remember the can't pee, can see, can shit, can spit, right? So all these sympathetic effects, which we call them what? Anticholinergic. Because remember cholinergic, muscarinic, so anticholinergic, okay? Yes, Kevin. Okay, that's a good one. So in the case of the blood vessels, we have effects on the arteries and the veins. And these effects actually vary, but the ultimate effect is actually increase in blood pressure. We will talk about this when we talk about cardiovascular drugs, okay? That's a good one. Yes, Melody. The yes, so the muscarinic receptors, anti-muscarinic, are normally referred to as anticholinergic. This is a good point. That's why I had this note here. So guys, whenever we say anticholinergic effect, you get all these anti-muscarinic effects. Now, in fact, to be more accurate, we should say anti-muscarinic effect, okay? Because when you say anticholinergic, it means it affects what? Both nicotinic and muscarinic. But really, these effects occur at the muscarinic effect, not the nicotinic. So this is confusing because many times we'll say, oh, this drug will give you the anticholinergic effect, and we stop. We do not say which receptors, but it's mainly muscarinic receptors. So it's, I guess, one problem that I guess we're not being accurate. Sometimes we say anticholinergic effect, but we should say antimuscarinic. Whenever we say anticholinergic, we actually refer to antimuscarinic, okay? So the antimuscarinic effects are the ones that produce all these, fight and flight, cannot see, cannot be, cannot, okay? I'm glad you asked this question. Okay, and then the salivation, what happens to the saliva? Okay, so in the parasympathetic increase, in the sympathetic it decrease. In fact, some of the senior citizens, when they have their problems controlling their saliva, I've seen some cases where they use atropine eye drops that they take the drops into their mouth, okay, to stop them from producing the saliva, okay. So it was one of the it was like shocking to me when I first saw the prescription, for eye drops, taking a few drops by mouth, like what? I mean, like, what are they doing? So. Oh my God. Okay. Yeah. Yeah, that would be tricky. Yeah. Okay. The eyes, what happens in the parasympathetic? The pupil is contracted. So contracted pupil, and here we have dilated pupil. What about the pressure of the eye? I like to think of the pressure of the eye in the same way I think of the body pressure, okay? Blood pressure. So in the case of the fight or flight, the eye pressure goes up, just like your blood pressure, okay? So here the pressure goes up, and here goes down. So why is this important, guys? The pressure, the eye pressure? Glaucoma. So glaucoma is an increase in the eye pressure. So when we have anti-glaucoma, we should look for something that stimulates the parasympathetic or block the adrenergic, okay? And then in the lungs, the bronchodilation or bronchoconstriction makes sense. You need more oxygen when you are, in a fight. So then this is constriction, bronchodilation. Why is this important? Can you think of an application where we would need something to cause bronchodilation? Asthma, thank you. You have a question? Yes, ma'am. Okay, dilation. So in the case of the sympathetic, it causes, you know, because you wanna, you know, your eyes, when you are stressed or you are like under, like, you know, fight or flight, your eye pupils like dilate, right? It's like you like trying to see what's going on. So your eye pupils dilate when you are under the fight or flight, which actually causes the effect when we see I cannot see, right? Cannot see, cannot pee, cannot, you know, because your eyes are open wide, so you cannot really. It's like you have this vision, this blurred vision. Okay. What is it? I'm sorry, I can't. Tunnel vision. What is it? What is that? I'm not sure. Uh-huh. Okay. Okay, I have to get back on this because as far as I know, the only time you get this, like, you know, the pupil being very constricted is like these drug addicts. Okay, so these drug addicts, you will see their pupil very constricted. Okay, because of that same parasympathetic effect. But normally, I mean, the anti-muscarinic effect or the fight and flight effect will cause your pupil to dilate. Okay? And sugar, what happens to the sugar? I'll go back to the liver. So it increases the sugar here. Here decreases the sugar. Cholesterol in the blood, what happens to the cholesterol in the case of the, again, you know? So remember, your liver rest and digest works more at night. Okay, so when you are resting, digesting, then your cholesterol is being, you know, broken down. Actually, cholesterol is increasing in your blood. Okay, that's why these cholesterol medications, Lipitor, atorvastatin, and all these statins are taken at night, because that's when the liver works the most. Okay, so in the case of the parasympathetic, there is an increase in the cholesterol. Here you have decrease in the cholesterol. Okay, you guys had questions. Yes. Respiration. Okay. So what do you think? The rate of the respiration. What happens when you are in fight or flight? Does it increase or decrease? Right. So you have the rate increases, and your bronchioles expand, so you could get more oxygen. Okay. Okay. Somebody else has a question? Yes, John.
Okay, I'm trying to get this more on a conceptual level that I can use later.
Sure.
What do you put in the eye for glaucoma? And which is it? Is it a adrenergic?
Okay.
Is it a blocker of one or a stimulator of the other?
That's a good question. Guys, so in all these applications, in the asthma and, you know, the glaucoma, which one can I use? Should I use the, you know, stimulate the sympathetic, like, you know, adrenergic agonist, or block the muscarinic receptors? Which one can I use? What do you think? If I say one but not the other, you better stop me, right? Because it wouldn't make sense. You could use both ways, right? Indeed, you will see drugs that are anti-muscarinic used to produce these effects, and drugs that are adrenergic to produce, again, these effects. So you could use both, okay? Normally, adrenergic are more selective because you have alpha, beta, and they're distributed in different parts, so you have less side effects, okay? So I'm preferred than the muscarinic. But in the case of the eye drops, because you are actually administering the drop directly into the eye, so there is only a small amount of the drug that will go into the circulation, so you could use the anti-muscarinic.
So when you treat glaucoma,
so actually, oh, I'm sorry. So with the glaucoma, we're talking about here. So we decrease the pressure by using, you know, by stimulating the parasympathetic or blocking the adrenergic. But the same concept applies, okay? I mean, what we actually use, we have drugs, we have eye drops that are actually parasympathetic, like physostigmine. Is it physostigmine? Okay, anyway, so we have drugs that are stimulating the parasympathetic, and we have drugs that block the adrenergic, like beta blocker, stimulon. There are drugs, yes, there are drugs for this or that.
I didn't want to, like, I wanted to be able to think of that.
Yes.
Only one class of drugs used for glaucoma.
Of course.
I wanted to learn that. And now, not know what they are, but just so it was conceptual in my head.
Yeah, yeah. So you could use both mechanisms. And speaking of that, I want to encourage you to trust your natural thinking, okay? If you see something that does not make sense, speak up. It's not your fault. Okay? If you see something that's contradicting or not clear, then it's not clear to everyone. It's not just you. Everything should be clear and simple in, melody. Okay, so glaucoma is an increase in blood pressure. Think of the blood pressure of the eye as the body blood pressure. So if in order to reduce the pressure of the eye, you think of reducing the blood pressure, which is reducing the sympathetic effect. So we are block the sympathetic effect or stimulate the parasympathetic effect. Okay, so we're talking about here, this side. You either produce parasympathetic or block the adrenergic. Okay, so now that we had all the concepts of how these different receptors work, this table makes sense now, right? Okay, so any questions about this exercise before we move to the next one? Yes. Okay, so blood vessels, there are effects on the arteries and vein. We will go to that when we talk about cardiovascular medications and drugs for blood pressure. But for now, think of when you constrict the blood vessels, what happens to the blood pressure? Goes up, right? So then which of these do you think would have increase in the blood pressure, and which one would cause decrease in blood pressure as far as vasoconstriction, vasodilation? So here we have a parasympathetic, so at vasodilation, the blood is not pressured. The sympathetic, we have vasoconstriction, so the blood vessels are constricted, blood pressure goes up.
Okay, so during the fight or flight, we have blood pressure go up because my thinking was we have more blood flow, so we should have a dilation instead of constriction. That's what I'm thinking.
Okay. Yeah, but yes, yeah, but true. So actually, so the volume of the blood is constant. So if you actually do the vasodilation, then you have less supply of the blood to the organs, right? They will be like accumulated in the major blood vessels and arteries. They are not going to be pushed to reach all the organs. If you constrict these veins and vessels, then the blood will reach everywhere, and that's your goal in the case of the fight. Okay. Okay. Other questions on this application? Okay, so if you got everything correct, raise your hand. Or this, if you're not sure. Okay, good, excellent. So the next one shows an example of the adrenergic receptor, noradrenaline. This is a life cycle for the adrenergic. Now think of this life cycle for other neurotransmitters such as acetylcholine, histamine, any of these neurotransmitters. They have something similar to this where the signal comes, the drug is synthesized, okay? It's stored in the vessel, and then the vessel is broken, excreted, bind to the receptor, and then in the case of acetylcholine, you have an enzyme that breaks the acetylcholine, but here we don't, the adrenaline, noradrenaline. And then once the drug binds, the noradrenaline binds, it goes back to carrier protein, or it could have also the autoreceptors, okay? So you have the carrier protein that absorbs it back and then break it into inactive form. So study this life cycle and look at these steps from 1 to 6, and your goal is to find the effect of this process on the signal. Is it gonna cause an agonist effect, or is it going to cause an antagonist effect? Basically, is it going to stimulate the signal or inhibit the signal? And the goal of this exercise is to consider all possible ways of how drugs act, okay? Because many times, if we cannot target one step, we could target the other, right? Make sense? So you have multiple ways of producing an agonist or antagonist effect. You guys need a break? Because you look tired. Okay, so let's take a break, refresh, come back. Let's make it a quick break, 5 to maximum 7 minutes. So at 11, 12, so we could actually work on this application, continue.
Hello, testing. Hello, how's everyone doing? Great, wonderful. Hey guys, don't forget that hi Kendra. That's so weird. Don't forget that your RSVP cards are due Saturday the 9th, but I turn them in Friday if I were you. And there's a box that's in the office that they have blank cards. So if you forgot yours, that's fine. Just make sure you fill that out. That's due by Friday. Well, it says Saturday, but Friday. Thank you. No.
Okay, so let's go through the exercise together. Hopefully you got the chance to look at them. Okay, so inhibiting tyrosine hydroxylase. If you inhibit tyrosine hydroxylase, what happens? Do you see an agonistic effect or antagonistic effect? Antagonist, right? Because you have less of the noradrenaline. Okay, and then inhibiting, or preventing the storage of noradrenaline into the vessels. Again, antagonist. And then prevent the release of noradrenaline. Again, another antagonist. Number 4, competing with the noradrenaline at the binding site. Antagonist. And then number 5, blocking the carrier protein. Antagonist. So if we block the reuptake of this, what happens? Okay, so noradrenaline binds, go back here. It should be, carried by this carrier protein inside, okay, to be degraded. But if we block it, what happens to the noradrenaline here? It's more, right? It stays here, then it can actually bind again. So what effect do you see? Agonist effect, okay? And then number 6, inhibiting the monoamine oxidase enzyme after the drug, after the noradrenaline is inside. If we prevent the metabolism, the breakdown of the noradrenaline, what happens? Agonist, because you have more of the noradrenaline inside, it could be stored again and it could be released. Okay, so 5 and 6 are agonists, the other 4 steps are antagonists, which actually agrees with the idea when we talked about which is easier to design, an agonist or antagonists, right? So many times it's easy to design antagonists. The only way we are able to design agonist is through these mechanisms. It's like indirect way of producing the noradrenaline. Yes, Melody. Okay, so number 6, noradrenaline is broken into the inactive form by this enzyme. So if you inhibit the enzyme, you'll have more of the noradrenaline that could be stored again and used and produced, the effect. So you have adrenergic effect. I'm sorry, agonist effect. Yeah, it's the same. You had a question too, right? Okay, yes, sir. Number 5 is this protein carries the noradrenaline back into the cell. If we stop it, if we block this carrier protein, we have more of the noradrenaline in this region, in the synaptic cleft area. So you have chance that it could actually bind back to the receptor and produce the agonist effect, okay? You had a question? Okay, the same. Right? If you got this 100%, raise your hand again. Excellent. All right. Next one. Explain the reasons for instability of acetylcholine and discuss the approaches used in stabilizing it. Okay, so let's set, let's say 7 minutes. At 11:25, we'll start discussing these together, okay? And hopefully maybe I can pull someone, guys, on this practice, I'm gonna, pull one of the groups and have you explain that to everyone, okay? You should be able to find the answer to this exercise in page 7 and page 10, okay? Are you guys ready? Ready? Okay. Do you have any volunteers first? No volunteers? Use my random number generation. I'm not going to ask you again. Yes, volunteer? Sure. Yeah, come on in. Team number 6. You're going to volunteer by yourself. Your team is supposed to support you, you know? They don't support you, right?
Explain the reasons for the instability of acetylcholine and discuss the approaches used in stabilizing it. So the reasons for instability is because it hydrolyzes quickly in the stomach acid, in the blood as well, and it's not specific to a target. It'll bind to every target. And approaches used in stabilizing it, the steric effect and the electronic effect. The steric effect, you add a methyl group, and then the electronic effect was, what was it again? The charges.
So with the steric effect, can you elaborate more on the steric effect? What does the methyl group do to the drug when we add it? So what's the name of the enzyme that breaks down the acetylcholine? Esterase.
Esterase, yeah.
So where is the ester in the group here? Where is the ester in the acetylcholine? Right here, right? C double bond O. So this is where the bond that's broken, right? So when we add the methyl group here, it actually makes it difficult for the enzyme. It makes it difficult for the enzyme to break this bond here, right? So it's called a steric hindrance. It acts as a shield to protect this bond. Okay. Now, as far as the electronic effect, it basically stabilizes the bond here. Again, the same ester bond. It stabilizes it, so it's not easily broken. Okay. Don't worry about too much, electronic, withdrawal or donating effect. Just, simply modifying this group, with what? Okay, the replacement of the methyl with the amine group would actually stabilize this double bond and prevents from the further breakdown. Okay, and then you have a combination of both effects here. Okay. Some drugs like this would have both effects. You could add methyl as well as the amine, okay? Which is why called, bethanyl, because you have both effects, okay? Is that clear, guys? Okay, thank you so much for your help. Thank you. Okay, questions? Yes, ma'am. Oh, what's the benefit? Just more stabilizing of the acetylcholine. So, instead of having one effect, you have two. So, just double the stabilization. Another question, yes, Melody? Yes, so the addition of the amine group would the amine has two electrons, the lone pair of electrons that they bind and they stabilize the other group, the esterase group, the ester group, so it actually prevents it from being broken down. So instead of the methyl, we had an amine, so it actually stabilizes the ester bond. Questions? You will see a lot of the steric effect in our, this course. You will see a lot of ways where we actually use the steric effect to prevent the breakdown of a bond, by an enzyme, okay? So this is a very important way we use to stabilize a drug. So if you got this 100%, raise your hand. Oh, great, good. Okay, the next one is actually something we talked about a little bit when we had the rat here. So the SAR for the acetylcholine and the SAR for the muscarinic receptors. So let's say you would take 5 minutes, maybe, to study. This is the SAR for the muscarinic receptors, and for the cholinergic receptors, look at page number 8. Okay, so page number 8 and this figure here should give you an idea of the SAR for the cholinergic agonist and the anti-muscarinic. So let's start discussion at 11:35. Okay. Okay, ready guys? Ready? Okay, let's start by the SAR of the cholinergic agonists, okay? So whenever we say SAR, we refer to studies that are performed such that we modify, the structure and see how that affects the activity, right? I mean, that's what SAR stands for, structure, activity, relationship. So we study the relationship between the structure and the activity, right? So these are some of the studies that were performed, and we came up to the conclusion that this should be the ideal acetylcholine agonist, okay? So in the first study, it says positively charged nitrogen is essential for activity. Replacing it with a neutral carbon atom would remove the activity. So what does that tell you about the receptor? It should have something binding to this positive charge, which is like a negative charge here, right? So if we substitute this nitrogen with a neutral atom or carbon, then this would drop the activity, okay? And then the ester function group is important. This ester is important because it's forming hydrogen bonds, okay? If you replace it with something else, again, you lose the activity. And then the size of the molecule cannot be altered much, okay? As you can tell, it's tightly fit into this binding site of the receptor. In fact, this sentence goes with the other one, which is actually goes with these two. The distance from the nitrogen and ester is important, and then ethylene bridge between the ester and nitrogen cannot be extended. So this is the ethylene bridge. If we extend it, make it 3, it's not gonna fit. If we make it shorter, then these will not fit as ideal, as good they are with the 2 carbons here with ethylene, okay? And then there must be 2 methyl groups on the nitrogen, 2, because they bind somewhere with the binding receptor. And then if a third group is tolerated, we could have a third group, but no more than 1 large group. So we cannot have like ethyl here and another ethyl here, for example, okay? So again, this should fit for hydrophobic interactions. And then bigger ester groups can lead to loss of activity. Again, here the ester, if this CH3 is bigger group like methyl, then you lose the activity. Why? Because it does not fit the receptor, okay? This is not something you need to memorize, okay? This is just, conceptual. So you look at the studies and you look at the receptor, it makes full sense. You appreciate what it means for, and that these features, why they are important for the activity of this drug, okay? Does that make sense, guys? Okay. So normally I never ask for, anybody to memorize SAR. So if I want to ask a question about this, I would provide this page for you, just like the one where you see on the screen. All these, lines and the image, and say, this is these studies. What do you think is going to happen if I design this molecule? Would you think it's going to be active or not? Okay. So then you would check these studies, make sure the new molecule fits them. If it does, then it would be an agonist, okay? If not, it wouldn't be, okay? So if I design a molecule and make this only, instead of 2 carbons, make it 1 carbon, right? So this does not fit the description of a SAR, a good agonist. So then it would be not active. Or if I modify, make any of these changes listed. So make sure you can use the information, not memorize them. Make sense? Okay, so questions about this before we talk about the SAR for the antimuscarinic? Yes. Excellent question. So, yeah. Uh-huh. Okay, so the question is, if I do any of these modifications, would it only lose the activity or produce an antagonist? What do you guys think? Well, we know for sure it's going to lose the activity, right? But is it guaranteed that it's going to produce an antagonist? Maybe a partial agonist or partial antagonist. We're not sure until we actually experiment it and test it, okay? So most likely, if I miss any of these points, then the resulting molecule will bind partially and then give you maybe a partial antagonist. But remember, for the antagonist, it has to compete with the, agonist to replace it to be full antagonist. Okay. We will actually, since I'm talking about it, so as you will see, the SAR for the antagonist, everything stays the same. I noticed here there's 3 carbons instead of 2. For some reason, it still works as an antagonist. But look what we did. We added this bulky group here. Okay. These aromatic rings, they find a region in the receptor where they bind and form van der Waals interactions at a different, binding region at the receptor. So because of this group, now the induced fit or the conformation change of the receptor is not leading to the signal transduction. Okay, is not giving the high five. It actually producing a different effect, and it's a full antagonist. Okay, so to follow up with this, the SAR for the antimuscarinic is basically the same, except we should have here, instead of methyl, we have this biphenyl group that they should be aligned this way, like to make like either a T shape or a U shape, okay, such that they can bind to that region of the receptor and form van der Waals interactions, which answers the other part, the second part of the exercise. Right, questions? If you get this 100%, raise your hand, or do this if you're not sure. Okay. So let me take 1 or 2 questions just to be sure. Yes. The comparison, okay. So if you look at the SAR for the agonist, it's exactly the same as the antagonist, except here we removed the methyl group and we added this biphenyl group, the aromatic groups. So these groups will form van der Waals interaction with another region at the receptor, okay? And they can form, so the overall interactions would be stronger than the acetylcholine, and that's why it acts as an antagonist. Plus, it produces a different induced fit that will not activate the receptor, will not give the high five or signal transduction. Okay. Another question. Yes. Uh-huh. Mm-hmm. Right. In the right. So all these instructions here were descriptions for the agonist. Okay, and it says this group cannot be bigger than a methyl group. If it's an ethyl, then it cannot be an agonist anymore. So imagine instead of replacing the methyl not with ethyl 2 carbons, but with this bulky huge aromatic. So it's like we're actually adding these 2 phenyl rings instead of the methyl. So first, we not only lost the agonist effect, but we produced an antagonist effect. Okay, so this is similar to the question Adishola was saying when he said, well, if we miss these rules, what happens? Well, yes, we will not get the agonist effect, but can we be sure about the antagonist? Maybe. We might get some antagonist, but partial maybe, but not full. To get a full antagonist, you need something large like this to bind to the receptor and strongly and displace the acetylcholine to produce the antagonist. Okay, so let's move to the next exercise. The theories explaining the mechanism of binding for nicotinic antagonist. Yes, John.
This probably goes into more depth here than we're required.
Okay.
But this is the antagonist, and mostly what it talks about is these larger groups causing antagonism.
Mhm.
Right here, it's saying that for an antagonist, this can be tertiary or quaternary. On which I know we're probably not going to have to know, but for an agonist, it must have a quaternary. Well, it seems to me like we're illustrating that this part's normal,
Mhm.
but it's showing this is a charge, and it's saying that on a agonist, I
Mhm.
mean on an antagonist, it can be tertiary or quaternary, and it end up being charged.
Okay.
But I mean, their explanation is confusing and almost seems to contradict their explanation. The simple explanation of this bottom part's normal is fine, and I would have been fine without. But this complicated thing that I probably don't need to know, I messed up and tried to understand.
Okay. So, so the question is, in the case of the acetylcholine, we had this positively charged. I don't want to make things more complicated, so I can answer the question after class. But I mean, to make it simple, guys, in order to force the nitrogen to be positively charged, I put 3 methyl groups. But if I leave it for the hydrogen atoms, then it's going to be partially charged. Remember the percentage of ionization and anionization? Remember how the pH and pKa of a function group can have, more or less ionized or unionized? Now, if I want to have 100% of the molecule ionized, then I replace all the hydrogens here with methyl groups, and that's it. They're fixed. They're ionized forever. Okay, so this will produce, a molecule that's 100% of the time ionized, and then will bind to the receptor. If I have 1 hydrogen here, then instead of any of these methyl groups, then I will have to go with the Henderson-Hasselbalch equation and decide how much of the drug is actually ionized, how much is not. Okay, so then, it could be ionized or unionized. If you don't get this, that's fine. I just wanted to answer his question for everyone, okay? Okay, so let's start with application number 5. Hopefully, if we finish 5, then we can finish, well, let's see. Well, actually, 6 is straightforward. It's just the importance of the carbamate group here. Let's see. And by the way, you should never, these steps here are only for your own information, okay? So do not worry about them. They just explain how the mechanism of, the degradation of the acetylcholine. So it's a long, and if you want to read it, that's fine. If not, it's fine. It just tells you that at the end, the acetylcholine is broken. The carbamate here, the importance of the carbamate is the fact that it makes this more stable, this intermediate in the whole reactions more stable. Why is this important? Because when this step is more stable, guess what? The drug is gonna stay longer at this site before it leaves. So it's a slow hydrolysis. By occupying the enzyme binding site, then the enzyme will be blocked for a longer amount of time, okay? So this carbamate was important, it was good because it actually stabilizes this step in the breakdown process. Just keep that in mind, we can talk about it more. Now, start working on exercise number 5. Hopefully maybe 5 minutes, and then we can talk about it another 5 minutes, and then we'll break. And then on Friday, we'll go back to see if you have any questions about these last 2 exercises. Okay, so start working exercise number 5. 5 minutes, and then we'll discuss, okay?
Your explanation.
Good.
They should have gone a little.
Do you want to start the discussion, or do you want to read it? You want to read the theories first, and then start the discussion? Start the discussion, raise your hand. Okay, okay. Okay, so there are 3 different theories, okay? What happened is when they discovered the molecule for these nicotinic receptors, they noticed that there are 2 positively charged that are far away from each other, right? And they noticed that both these positive charges are important and they should be located within this distance. If they remove one of them, then the drug is not able to bind to the nicotinic receptor and block it, okay? And here we're talking about the nicotinic receptors. These are receptors that bind to the, skeletal muscles, okay? So the theory was they initially thought that maybe there are 2 binding sites, 2 acetylcholine binding sites at the receptor, okay? And the distance between them is similar to the distance between these 2 positively charged. But then it turns out that no, the distance is much bigger, so there's no way this can fit these 2 binding sites. Look, these are 2 binding sites, and this cannot fit these 2, okay? So that's theory number 1. Theory number 2, they thought, well, maybe they bind to 2 nicotinic receptors. So we're not talking about 1 nicotinic receptor. We have 1 nicotinic receptor, there's another nicotinic receptor, they are close to each other, and then this drug cross binds to 2 different nicotinic receptors. Okay, but then again, the distance between any 2 was like 9 to 10 nanometer, and this distance is like 1.15 nanometers. So this did not work. The last or the third theory was that there's another negatively charged thiol group here next to the binding site, where these 2 positively charged bind one of them to the acetylcholine receptor, and the other positively charged bind to the thiol negatively charged group, and the distance between these 2 was in line with the distance between the 2 positively charged nitrogens. Okay? Does that make sense? No? Yes? Okay, I need someone to explain it. Okay, let me see if you guys got this, can you please help me explain it like to your teammates? John, you want to try?
I want to try because I'm thinking I have some understanding of how this
Sure.
possibly works,
Come on in.
but I'm going to be shot down because I skimmed it trying to understand it for a different thing.
Okay, give it a shot.
Okay, I'm guessing that, and I don't understand how acetylcholine fits into this because it doesn't seem to have these charges separate. There's another drug that looks like acetylcholine bound to itself end to end that seems to stimulate this receptor. But looking at tubocurarine, it looked like this big molecule, and I'm guessing from this part right here, tubocurarine or any other thing that has this and this, when you add this drug, what actually happens is it groups together like this kind of shape and touches all this. Is this correct, or is this totally off the wall?
Well, this is in line, but
It looks, I thought it was the confirmation of the things go together and touch each section of the tubular receptor.
Okay. Okay. So let me explain again.
But-
But thank you.
I may
Thanks
be
for trying.
wrong, that's-
Okay, no, that's fine. So guys, the issue is we have two positively charged nitrogens, and the distance between them is 1.15. Okay, and we are not sure where they bind. Okay, so they checked the distance between two different binding sites for acetylcholine, and it was much higher than the 1.15. So there's no way this can bind to these two. Okay, this theory is eliminated. Another theory was, what if there is one receptor, another one next to it, and this drug binds to these two, and then when they check the distance between one nicotinic receptor and another, it was like 9 to 10 nanometer. So it's again not equal to the 1.15 nanometer. So that's eliminated too. The third one was that next to the acetylcholine, there is a thiol group, negatively charged. And remember, the acetylcholine has a positive charge group, remember? In the SAR, or they need to show this again. Okay, so remember the negative charge here from the receptor. This is the acetylcholine. This is the, I'm sorry, the muscarinic nicotinic receptor. This is where the carboxylate negative charge binds to one of these positive charges. Okay, so back to here. Okay, so they looked at the distance between this thiol group and the acetylcholine receptor, and the distance was matching the distance between these two positively charged nitrogens. Okay, so three different theories. One of them says that the drug binds to two different nicotinic receptors. One says no, it's within the same nicotinic receptor, but two different acetylcholine binding sites. But then the third one says no, that it's one binding site, but it binds to another thiol group negatively charged, which is the correct one. Okay. And how did we find out? By measuring the distance between the two nitrogens and these distances for these other theories.
So, but you're talking about the drugs that are analogs for it that happen to bind it. They're going, the drugs that are analogs or
Yes.
have this binding distance. How does, but acetylcholine binds without having, like,
Oh,
it only has one nitrogen. So
right.
I'm wondering-
Right. So the acetylcholine binds to one of them and stimulate the receptor and produces agonist effect. Here, we're talking about the antagonist effect. We're talking about anti-nicotinic. That's a good question. So here we're talking about all these drugs are anti-nicotinic. They act on the skeletal muscles or the nicotinic receptors. So we were not sure how they bind, what's their SAR, right? So the goal is to study the SAR for these drugs. So we're not sure what's the SAR for them. And that's why we wanted to analyze and study, see where they bind, why should we have this distance, and anything below or more will produce inactive drug.
So is the distance causing a stability, like it's like scaffolding the receptor and it can't change?
No, this drug actually only blocks the nicotinic receptor. It blocks the acetylcholine, prevents it from binding. Melody.
Is it enough to just kind of know here that the first two were disproved because it's not based on distance and that for those
Yeah,
can work
because-
as hard as-
Exactly. Yeah, very simple. Thank you.
So it isn't the distance, and even though like succinylmethonium has the same amount, is it the same amount distance as purine?
Okay, we'll talk more after class. Okay.
I'm not sure I get
Right. Let me see. I just want to get a general idea. How many of you got this 100%? Raise your hand. 50, do this. Okay. Okay. So okay, that's fine. So next class, Friday, the first 5 or 10 minutes will visit this exercise 5 and 6. Or if you have questions, you can, I have office hours right after class. Remember also on Friday, we will have review session right after class. So between 12 and 1, make sure, bring your lunch, that's fine. So we'll stay here, 12 to 1, 1:30 or 2 o'clock, however it takes to, go through any questions you have. I don't have any, like material to go through, so I'll wait for your questions, okay? So make sure you are prepared and bring questions to the review session. You have a question? Yes. Shh, guys, I'm sorry. Yes, there's an IRAT on Friday. I'm sorry? Right, but we have to cover that material. So, and I know you're not going to study unless there is a rat, okay? Yes, of course. Yeah, so today, yeah, of course, today's class will be part of the CAT, yes. Okay, I'll see you on Friday. Thank you so much. Guys, make sure you give me the sign-on sheet, okay? And if you have any notes about something difficult, point it out. Okay, thank you.